Partial funding for the operation of this channel is provided by the City of Oceanside. The content of the program and opinions expressed in PEG Access programs are the sole responsibility of the program producers.
Welcome to this edition of Faith and the Common Good. We are so pleased that you have joined us once more for a conversation that looks at the issues of our community from a faith perspective. Our guests today are Dr. Carola Hauer and Mr. Jim Hamilton, who are a licensed clinical psychologist and a certified recreational therapist and chaplain serving the Tri-City Hospital services in the Behavioral Sciences Department. We are so pleased that they have joined us, and we look forward to this conversation on mental health. Welcome, Dr. Hauer, and welcome, Mr. Hamilton. Jim and Carola, if you don't mind my calling you that. If you would please offer for us a definition of mental health.
You know, I just recently spoke about that, and I just kind of put a list together, and I think this is a way of looking at it. For example, we want to be able to contribute effectively to the life of the community. We want to be able to have some type of relationships. Dealing with our temper, for example, and being able to just kind of modify it depending on the situation and not going outside the bounds of that. Acceptance of handicaps, the courage to change things we can change and accept the ones that we cannot. The courage to take risks and to be involved in activities to a degree where it doesn't endanger us or endanger anybody else. So those are some of the parameters, including obviously that we can take care of our personal needs, that we can take care of some of our family members, whatever our responsibilities are. But you can do that in a way that it doesn't get anybody into any type of risk and it doesn't overwhelm us.
So it's a matter of the risk to self as well as the risk to others as it relates to what we consider quote unquote normal. And as we were speaking just a few minutes ago, normal is without definition, and so we are finding ourselves defining again what normal is. What are the symptoms of mental illness?
Symptoms of mental illness can be so complex. They can go anywhere from depression to psychosis, to any mood disorders, thought disorders, and they can go to suicidality and homicidality. I like to call it kind of the human spectrum. And so the question is, where are we on that human spectrum? And it's really, I think it's really important to kind of localize and have an understanding, have an awareness, and check in. I think that's one of the things that we haven't been taught to do enough. Like check in and say, where am I today?
So specifically we're talking, and the list is numerous, we're talking about panic attacks, we're talking about schizophrenia, bipolar disorder, anxiety attacks of any kind, post-traumatic stress, eating disorders. Would there be others?
Personality disorders, exactly. I would take a look at the low end of the spectrum. In the very beginning, a lot of people are developing some type of depression, which doesn't have to be quote unquote a clinical depression, but can be impairing us from doing things that we are usually doing. And then it can get more serious, and it can kind of freeze us, and it can also lead to psychosis. And psychosis would really be that it's a loss of reality. And that can come with paranoia, it can come with delusions, it can come with auditory hallucinations. And so it's a gradual increase. But then there's other mental disorders, which I've been working with a lot, and those are things where people are working, they are accomplished, they go into universities, and they have a break out of nowhere, which could be like a bipolar break, could be a break for schizophrenia, and they come on in early adulthood. There are some age brackets, and they're very devastating because you have somebody who is very, very accomplished and doing very well in school, and all of a sudden has lost absolute all reality and all coping.
And sometimes that could be created by unbalanced stress or extended grief.
It can, but it can also be, there's a genetic component to schizophrenia, and it can just simply come out of the blue. So we don't necessarily have any precipitating factors. It's just developing. The other thing that I would like to caution is like extended drug use can take any type of diagnosis that's underlying, that may be latent for a long, long time, and push it to the surface. So I have seen that a lot in bipolar. And it's devastating, because you take a person who was very, very functional and is now fighting for a baseline to just take care of themselves.
So, for example, the long-term use of marijuana can certainly affect one's personality.
It certainly has effects, but there is stronger drugs. You know, there's a lot of methamphetamine in this area. There's heroin. There's all sorts of things.
The spice and talking about the marijuana, I have someone that close to me that has had their grandchild try marijuana, and it sent them into psychosis and the bipolar mood. So they're dealing with that right now. It's kind of a drug-induced psychosis, and as Dr. Howard stated, it's it may be latent, but it's now become active from that drug. So that's something that's everyone could be subject to, but you just don't know.
And so then, related to that, what would be the indicators that someone is in need of mental health assistance, whether clinical support or other support?
Well, it's different depending on mood disorders and thought disorders. So the mood disorders, in a lot of times, is where the person can't cope anymore, where the person isolates, where they stop doing things that they have been enjoying in the past. There's a lot of withdrawal. So we want to look for those things. And certainly, unfortunately, chemical dependency goes right into that, because it's used as coping an awful lot of times. So then we have a mixture, and a lot of families have to deal now with somebody who is not only experiencing those symptoms, but they're exponentially increased, because now, let's say, we have added alcohol to it. So that in that case, we're talking about a dual diagnosis, but it's just kind of compounded. The other ones, you will see people with psychosis just doing things that they haven't been doing before, and people around us are not necessarily doing. So they may be focused on internal voices. They may be really convinced that somebody's following constantly, that somebody is controlling their life or their breath or their thoughts. So there's a huge spectrum, but I would say when somebody deviates from their baseline to what we have been seeing in the past, it doesn't always have to be mental illness, but we should kind of at least consider it.
And with that in mind, the church, if one is a member of the church, the synagogue or the mosque or other faith communities, the leaders of those entities are usually the first persons that are reached out to by persons who find themselves a little less able to cope, or finding themselves struggling with day-to-day activities, or finding themselves withdrawing more, or feeling perhaps suicidal tendencies.
Feeling
and the
worthless,
like.
feeling hopeless,
Yes.
feeling that they don't fit into the community anymore.
Yes.
Exactly.
Yes.
And that's where they go. I think they feel comfortable with, with the religious clergy that they can go to and talk to in confidence that they can get help from them. And I think that's why they're the first outreach.
Now, it is true that those who attend seminary or some kind of clerical training are given an orientation to the issues. I was fortunate in that my seminary had a focus on clinical issues. In addition to that, there are opportunities to serve in clinical settings in the hospitals, and you are exposed perhaps to a little more of the urgencies and are able to begin to recognize some of the concerns and some of the points of recognition that then help you to realize that attention is needed. But in many cases, training is not offered to or has not been part of one's preparation for clergy leadership. What do you suggest?
Well, I would suggest that what I do when I'm in the hospital and I work with an individual who has a lot of spiritual issues, I will definitely get the chaplain involved. And I would hope that it would go the other way around. Reach out for the mental health professionals. I think it's hugely important that we work as a team. Most important, in my opinion, is that we're not judgmental. And I was just reading something today, that we don't go to right and wrong, but that maybe we can go to sense and nonsensical or something like that. But that's one of the added pressures, actually, for somebody who doesn't feel that they're fitting anymore, somebody who is actually withdrawing, somebody feels that they have let down themselves or God. To then go somewhere and speak about it is very, very difficult. And the other thing is we don't have really a vocabulary to talk about it. We are not really in a place where we can just express our feelings and they're simply accepted. We're always talking in abstracts, and I think we need to come to like a really good level of communication where I can just talk about my symptoms and can get something back that's not overwhelming.
And in addition to that, the issue is really integrated. It's a matter of biology, it's a matter of emotion, mental, it's a matter of spiritual, and the complexities of relationship. And so how do you find a way into conversation with someone who has come seeking support? How do you begin?
I feel that it's a process. It may be close to prayer, actually, but it's communication that evolves if we allow it to evolve. I believe that psyche speaks. You know, my background is in-depth psychology, and I always look for soul, sacred space, and I let the person talk. And a lot of times they will bring the issue right to the table. It's really listening to it and listening to it with an open mind. And have a lot of empathy, a lot of acceptance, not just tolerance, but acceptance. I'm thinking about, for example, some people are in a very, very difficult state of mind just because medication has been changed. And that doesn't mean it's not working or we should stir them away from that. It just means medication changes are difficult. And the more support we have, and the more we can normalize that, the less anxiety we have, and the more the body will work with that just as much as the mind.
Well, is it fair to say whether it is a clinical support network or whether it is a congregational or faith community support network, it's really about developing relationship that is offered without judgment, that is offered with compassion and a willingness to be supportive through the concern. We find, especially in faith communities that tend to develop their own cycle of living and own patterns of time use, et cetera, it's difficult sometimes to deal with a person who needs just a little bit more attention. And the work then really becomes that of compassionate place. It really does become that of being willing to journey with someone through their most difficult times, and then being willing to refer them on when it's necessary to do so.
Absolutely. And I think some more faith communities are establishing those ministries that marriage family therapists are now employed by the churches and everything, and that gives them a place to go to and someone to talk to, and if they need further counseling, they can refer out, as you're saying. But I think those people, you know, are gaining some experience from talking with those people and are better able to handle that now.
Dr. Hauer, you were speaking about this notion of journey, and from beginnings of the support that is needed to a point of some either reconciliation or resolve or reconnection with relationship and with surroundings. Would you please continue?
Yeah. I have an opportunity because I'm not only working at the hospital, I also work outpatient because I would like to still see the journey unfold. I think I've specialized a bit in bipolar treatment, and I have seen some really incredible progress because, number one, it's a long-term treatment, but the components that have really helped some fantastic human beings that I'm working with were probably emergency medication, long-term treatment with a psychologist or a therapist, and then really educating and helping the support system as well as the patient. How can we build a structure that I can actually fall back on if I'm actually having another psychotic episode. And I have worked with a couple of young females who have actually been able to reintegrate into a full life after some serious, one had very serious suicidality and was struggling to stay alive, actually struggling not to kill herself, not to stay alive. And at this point actually verbalizes that now she's fighting for her life. And another young woman who went through very, very severe psychotic episodes with like incredible paranoia. And the interesting part in her journey, actually, when she was in the hospital, you could actually see the soul fighting on the inside while the paranoia was presenting. And this young woman also has been able to find the kind of the mixture that's necessary. So she has a psychiatrist that is responding to when we notice that the episodes are coming on. There's immediate change in the medication, which is reasonable, it's just an adjustment, helps through the episodes, and then brings her right back to a baseline. In doing that, patients don't have to suffer through the biggest episodes because that leaves like a residual, and that makes it even worse. Mm-hmm. So I've seen a good number of people get to a place where they get their dignity back and have a lot of functioning.
Mm-hmm. Yes, that's wonderful to hear, and I like the frame, returning to dignity. In so many ways, persons who feel that suicide is their only option or feel as if they do not have a support system are recovered. And in Christian thought particularly, we're looking at the restoration ministry of Jesus, the reconciliation ministry of Jesus, where we find persons who are able to come back to themselves in ways then that help them to be productive.
And to forgive themselves.
Yes.
And have families forgive them.
Yes.
Psychologically, we talk about letting go, which is very similar to the issue of forgiveness, which is really important because patients feel that they have let God down. Yes. And we point out many, many times that God most likely has forgiven them a long time before they're even capable to begin the process.
Right. Well, that leads us then into the conversation about the role of church, the role of synagogue, the role of mosque, and other faith entities in this discussion. As we noted earlier, it is true that the first place of contact for many to reach out to would be an entity of faith, a leader in that faith community. And we find that even sometimes within those communities there are stigmas that are associated with support to persons with mental health concerns. And there is an unwillingness in many ways to reveal that there is a concern, especially when it comes to the point of suicide. I myself have, at least on 3 occasions, have had to walk someone through that suicidal moment, having been in a re-entry moment, and this is post-jail exit, not post-military service, but post-jail exit, where persons are attempting to reorient to civil society, and the same would be true with military, and especially there as it relates to post-traumatic stress disorders and the like. So Jim, your work is around the invitation to faith communities to become more aware and more prepared to address the concerns. Would you speak to that, please?
Absolutely. I do chaplaincy in the jail, so that's where I work, and some of them, people, as we've been talking about, have lost hope, and the families have turned against them because they've used up their last wish with them, and they've failed, and they don't see any way out, and they're very helpless and hopeless. And so we tried to bring the faith, hope, and love back into them, and try to reconnect them with family and with services on the outside. Especially ourselves, as being a chaplain in a faith community, we go and talk with them and to provide that faith, hope, and love to them.
Mm-hmm. Mm-hmm. Your experiences are beyond the jail, in that you have now begun to gather together through your work at Tri-City Hospital, faith leaders in the area, to develop support networks in that way.
And we've the mission was to get the local clergy of the churches involved and to understand this, the impact of this mental health is on our communities, on their communities, and how we can embrace this and come together to form this alliance and to tackle this this problem. So the first workshop, I believe, was very successful in this local area, and now we're going to do ongoing workshops to invite the community too, so they can hear it firsthand and they can see what the problem is and what resources are available for them.
Mm-hmm. And so, for example, perhaps a detail of one of the workshops might be a modeling of ways to respond to someone who is suicidal.
Correct, and that might be the next one, actually. Chip has a program.
I was reading your mind.
Yeah. Chip has a program. It's called QPR, and it's question, persuade, and respond. And they are awesome too. They're up with the big three, the 211, NAMI, and Chip are very big in as mental health advocates. So they are putting on a lot of programs and services for the mental health community. So again, they might be our next workshop.
Mm-hmm. And then another could perhaps be the work around the first contact within an office setting or reception setting, telephone contact or personal contact. Can you talk about just a little bit about how someone who is serving in a reception capacity or someone who is the initial office contact could perhaps support?
I think that would actually be better for Dr. Hauer.
Well,
I mean, she's... Yeah.
Use our emergency room, for example. The use of the emergency room is very important, and I think that there's not a wide and broad understanding that we have 24/7 clinicians on board who can actually respond immediately to a crisis. So that's a really important. I mean, there's also PERT, the psychological emergency response team, that rides with police. There's also police, but I would always prefer to actually be brought in by somebody who cares, somebody who can de-escalate me, somebody who can kind of like speak for the person who is struggling, because it's not necessarily that you can be very communicative when you're experiencing psychosis.
Sure. And by de-escalate, for the benefit of our hearers, what are you speaking about?
De-escalation, the first response to somebody who is disturbed is to respond in a way that we can maybe contain the situation a little bit in really in an emotional way. So we lower our voice, it's our body, it's our posture, it's our gesturing, it's how we look at them. It's nice to be actually next to the person and not necessarily in front of them or look down or anything, but just position yourself next to the person and start talking and just asking questions. What are you experiencing right now? And how can I help you? What is it that you need right now? Those are very, very simple questions. Is it okay if I do X, Y, Z? Would you like me to reach out for you? Would it be okay with you if we went somewhere and got some professional help? People will respond very well to that. It just really needs to be on a level where we don't increase the anxiety. And we have to get past a couple of things. I mean, there's some resistance sometimes when, you experience somebody who, let's say, starts screaming. A lot of times the initial response is to get away from it. But it's actually probably much more helpful to be with that person, even to walk them and not necessarily allow the movement and if it's safe, obviously. So there's always a scanning that the situation is safe. But if we have a big parking lot at a church, it's okay to walk that person for a moment and allow the body to move, because it may be very helpful.
Yes, we find that, and Jim, this would come back to this connection between faith and clinical services. We find a lot of increased conversation about the issue due to the suicide of Rick Warren's son this about this time last year, and Pastor Warren has begun to coalesce some of his resources, having convened just the end of last month a mental health conference. And I say that in connection with what you're saying, Dr. Hauer, because Father Van, who was one of the co-sponsors of the event, spoke about taking someone from that stress moment and walking with them, and in that moment of walking with them, the physical activity of reducing the hormone levels and the other places of anxiety, helping then to open the way for the conversation to happen. And it's also a reminder for us that the matter is less about fear response and more about human response. In the same way that we would extend a hand to a child who has fallen off of a bicycle, we extend an opportunity for conversation and relationship with someone who is having difficulty emotionally or mentally.
And we have to have that same present too. When we're offering that hand, it's a hand of comfort, a hand of love, and and I'm just here for you, and I want you to know that. And we're going to go through this. It's okay. It's okay.
One or two resources. Could you lift up examples of resources that are available to the general public in our area?
Well, first of all, NAMI is the greatest resource of all. They're the National Alliance of Mental Illness, and I think they're in almost every community in here, and they're wonderful. They're awesome. They have a lot of support groups for the needs of the family, the patient, aftercare. We have invited them in our lobby, so they're the first point of contact once you come into our lobby on the behavioral health unit, because a lot of times this is the first break of your son or your daughter that are 18 years old, and they don't know what they're supposed to do or what they're going to go through. So they can sit there and explain to them, well, this is kind of the process, this is what's going to happen, and just to give them some information about what's there to expect.
And then also, is it relatively new, or has it been in existence for a while, the 211?
211 is a fabulous resource. It takes some patience, and it's very difficult sometimes for patients actually to do that themselves. So I often dial the number and help them out and ask questions, because the more specific you are, the more specific resources you're getting. It's housing, it's mental health, it's all sorts of things. It's economical. But the patient who is in distress is really having a difficult time to even verbalize anything. So it's very helpful to step in as an advocate and to ask the questions that are really, really important. And even being on hold for 10 minutes.
Sure.
It's stressful.
Absolutely so. Is there one point that you would make about addressing the concerns of mental health? A way of informing our audience or a way of encouraging our audience?
I would say if somebody talks about suicide, that I would just simply take that absolutely serious. Be not afraid, go find the right resources. And just going to the ER doesn't mean patients are necessarily hospitalized. Many people, we can stabilize the crisis. It is simply talking about it. Sometimes it gives the patient an opportunity to say how big the crisis is and to be heard and potentially return to a level of coping. But anybody talks about any type of suicidal ideations, I would just straightforward ask questions: when, where, how, what, have you made any plans, in a really compassionate way, and say, you know what, I want to keep you safe and I'm going to help you to get somewhere. And if people are not willing to do that, then I would certainly intervene, and I would certainly call 911 and just report what has happened and let them sift it out. But that's a really huge, important one. And remember that alcohol exponentially increases the risk for suicide, especially when patients come off it. So we don't want to take a chance. The suicidality in Oceanside, the level of suicidality, I started working at the hospital in 2005. We are seeing such an increased number, and also in the aging population, unfortunately, and I would hope that we could respond quicker. And I think church and mental health, if we combine our effort, I think we can catch more people, because it's a huge number at this point.
I want to thank you, Jim, and thank you, Dr. Hauer, for being here today and for your expertise and for your patience and forthness in moving toward resolve to our concerns. Thank you for watching this episode of Faith and the Common Good, and we look forward to seeing you next time.